good morning or afternoon, depending upon where you are in the country. This is Gloria Miele from the Greater New York Node, and welcome to the 2010 webinar series that is put on by the Clinical Coordinating Center. I am Gloria Miele, and I will be directing your training today. So welcome, everyone. So we will be covering a number of topics today in our session. The first thing we're going to do is review various drugs of abuse. We're going to look at intoxication and withdrawal syndromes of the various drug classes. We're also going to review DSM-4 substance abuse criteria, DSM-4 substance dependence criteria, and then just briefly talk about some of the commonly used methods and procedures to evaluate substance use, abuse, and dependence. Obviously, this is a hot topic for the Clinical Trials Network. Our mission is to do research in substance use disorders and problems related to substance use. And with new protocols starting and new staff coming on and being trained, it's always good to have introductions to this area. I think there's a lot of times where people come in as research staff. They don't have a lot of background in substance abuse research, a lot of understanding of the different drug classes and drugs of abuse. And so that's why we've put this training together today to serve as this type of introduction, really more for novice staff who are new to the CTN and to substance abuse research. I'm sure we also have some more experienced staff on board. We, as was said, as Lisa mentioned in the introduction, we do encourage comments and questions. We have the lines muted to start just to create a quiet environment for the recording of this webinar, but we will be stopping for questions and comments as we go along. Drug abuse research and drug classes are constantly changing. You'll be amazed as you get into this field and start talking to people when you start learning about the different kinds of drugs that people are using. And so this is some pretty up-to-date information. There's probably more and different drugs coming out as we speak. But we're going to start with some of the basics and go from there. So just as a slide to put some things in context, these are some data that came out of a SAMHSA study that was published last year, and this is drug use prevalence in people aged 12 or older in the United States in 2009. So you can see almost 22% of people aged 12 or older have used some kind of illicit drug, and that's like any of these that are listed here, some type of illicit drug in the past month in 2009. The most prevalent of those is marijuana at almost 17%. In this study, psychotherapeutics are lumped together to be any kind of medication that might be used illicitly. So this would be painkillers or sedatives are kind of lumped together in psychotherapeutics, and we'll get into the differences between those as we go along. About 1.6% of people used cocaine, 1.3% used hallucinogens, 0.6% used inhalants, and 0.2% used heroin. And as we participate in drug abuse research, I think we tend to think these base rates are much higher than they are because we're talking to people who are in substance abuse treatment. So our samples are kind of biased because these are the people who we see. But in the general population, these are some of the findings that came out last year. And again, just wanted to provide this as a context of the rates of substance use in the general population. So let's get started talking about different drug classes and drugs of abuse. And I have to say, once again, Liz Buttrey has outdone herself by providing some great graphics on these slides to give you some demonstrations or some images to go with the text of the various drugs of abuse. So we'll start with alcohol and other sedatives. And there's a learning point, I think, right there. Some people are not aware that alcohol and sedatives really have the same kinds of mechanisms of action, that alcohol is a sedative. So we can look at them together because they have the same types of effects when you use them and the same types of effects when you're coming off of them. So everybody knows what alcohol is, and there are different ways of classifying alcohol use based on standard drinks, and that information is available on the NIDA website and the NIAAA website. We use standard drink measures when we assess substance use using the timeline follow back. And I'm getting a little ahead of myself, but we all obviously know about alcohol and drinking. And then there are other classes of sedatives. So there are benzodiazepines, and we're going to talk about not only the generic name of the drug, but then also some of the commonly used names. So when you're possibly doing an interview with somebody, people will talk about drugs in different ways. Not everybody's going to call it a benzodiazepine. Probably few people will, but they'll refer to it in different ways. And it's important to know what class of drug certain drugs fall into. So benzodiazepines are things like Valium, Ativan, Xanax. People call them downers. So those kinds of sedatives that you commonly see used in people who are using other types of substances. Barbiturates like phenobarbital, seconal, reds, and yellows. Again, a different type of drug, but still under the drug class sedatives. Rohypnol is a drug that people might have heard about recently. This is the date rape drug that you might have heard people, somebody might slip something in somebody's drink and it knocks them out. That's Rohypnol, also known as Ruvies. And then we also have other sedatives here, GHB and Quaaludes. Quaaludes were more popular, I think, in the 70s than they are now. But if you're looking at somebody's substance use in their lifetime, they may talk to you about their Quaalude use. And that is another sedative. All right, so that's our first drug class, alcohol and other sedatives. So our next drug class are heroin and other opiates. And here we have heroin which is usually used either by injecting or snorting, and that's called dope, smack, H-horse. People can refer to it in all those different ways. And then there are all kinds of other opiates. These are typically used as painkillers and are often prescribed as painkillers. And we've done studies in the CTN of people who are on prescription pain medication and ways of treating them as well. In fact, abuse of prescription drugs, specifically prescription opiates, is on the rise. And that's one of the reasons we have been focusing on it in the CTN. So what are some of the opiates that you might hear about? Well, things like oxycodone, codeine, morphine, Dilaudid, Vicodin, and you might have gotten a prescription for one of these from a dentist or an orthopedist. And these are commonly prescribed for pain, but also commonly abused. And often people can develop problems with them because of pain and develop tolerance to these drugs and end up taking much more than prescribed. Hydrocodone, fentanyl, of course, methadone and Suboxone. Methadone and Suboxone are used typically to help people detox or recover from the effects of withdrawal from other opiates, but these drugs can also be targets of abuse. They don't really get people high per se. They may get them drowsy. It's not something that you get the same kind of high that you would get from heroin or possibly Vicodin, but they do have some abuse liability despite the fact that they're typically used as a treatment for people withdrawing from those other drugs. Our next drug class is cocaine and other stimulants. Like with alcohol and sedatives, cocaine and stimulants go in the same drug class. They have the same type of mechanisms of action. So cocaine, other words for cocaine are blow, coke, crack, rock, toot. That's the way you might hear people refer to cocaine. And the other, I think, most common stimulant being used today that people have heard about probably is methamphetamine. And meth is usually manufactured by people, sometimes in their basements, kind of a home kind of service where they make this drug with various compounds, and some of the different names for that are crank, crystal, ice, or meth. And so that's how you might hear that referred to. And those are all stimulants. Oftentimes, well, with cocaine and meth, they might be used by snorting or injecting, just similarly to opiates. All right, cannabinoids, commonly known as pot or marijuana. And here we have a number of different typical ways that people refer to marijuana, some more typical than others, obviously. Not everybody's going to call it ganja, but people often call it pot or weed. Hash is in the same drug class. That's all under the cannabis mantle. Recently, there have been a number of synthetic formulations of cannabis, and those are called Spice, K2, and those can be bought over the counter. Those sometimes you can buy them even at convenience stores. And they have similar mechanisms of action, again, drug action, to cannabis, and kind of bind to the same receptors. My background is as a clinical psychologist. I'm not a science, I'm not a brain science person. I'm not going to talk so much, really, at all about the brain science of the mechanisms of actions for drugs. That, if people are really interested in that, definitely let the clinical coordinating center know, and maybe we can get somebody on board to do a more intensive seminar on that topic, which could be very interesting. But anyway, we need to know that there are some synthetic formulations of these that we may need to capture in our interviewing. Then there are psychedelics. These are hallucinogens like LSD, mescaline, mushrooms, peyote. Also dissociative drugs like ketamine, which is also known as Special K, PCP, and angel dust. These are, again, drugs that have been around for a long time, kind of come in and out of fashion. I think the drug in this class that is most in fashion right now is one called MDMA, which is more commonly known as ecstasy. And the important thing to know here, and depending upon what source you see, this drug can be classified as a psychedelic, or it can be classified as a stimulant because it also has stimulant properties. So this would be an important thing to determine if you're working on a study where the principal investigator of the study, the lead investigator, wants a drug like this coded. Do they want it in the stimulants or do they want it in the psychedelics? I think in the CTN we have typically coded it in the psychedelics. So, but just something to know that it does have both mechanisms of action. All right. So before we move on to the next topic of intoxication and withdrawal, let's go ahead and do some polling questions about these different drug classes that we just reviewed.
Okay. I'm going to take us over to the first polling question, Gloria.
Okay. No, that's not the one.
No.
It's a preview for the next one. Okay, so we're going to get rid of that. Oops. That's not the polling question. Let's look at that one. Okay. Is everybody seeing this one? Liz, you with me?
My screen froze up. I'm working remotely, so.
Okay, so I got it. Valium, Seconal, and Xanax are all part of this drug class.
Okay, the polls are open.
Do you think it's hallucinogens, opiates, stimulants, or sedatives? We still have some voting going on.
Okay, let me go ahead and show the results. And I'll go ahead and close the polls.
All right, so the predominant response, which is the correct response, is these are all sedatives: Valium, Seconal, Xanax. Seconal is a barbiturate, which is different than the benzodiazepines, but they are still all sedatives. So good job. People are pretty on track with the sedatives. Great. You want to try to pull the next one up, or would you like me to try?
Give it a shot. Here we go.
Okay, here we go. Ketamine and ecstasy are part of this drug class. Would it be hallucinogens, opiates, stimulants, or sedatives? Polls are open.
All right, Gloria, I'm going to go ahead and show results.
Great.
There you go.
And again, 80% of folks classified it under hallucinogens, which is the correct drug class. A little bit of a trick question, because I did say that ecstasy also contains stimulants. So if you were answering based on that piece of information, okay, I'll take that. But I also mentioned that in the CTN, we typically code ecstasy in the hallucinogen category. So again, something to check with the lead investigator of the protocol, or your project manager, somebody on the protocol you're running, where that would go.
Okay.
All right. Let's take this. What is a common name for methamphetamine? Crank, crack, snow, yellow jackets. Polls are open. I love these polling questions.
I know, they're great, aren't they?
Yeah. And while people are voting, I'll just give a plug for Liz Guthrie, who does a great job putting these webinars together and has worked. It's always a pleasure working with Liz, getting these things set up, and using her expertise to make these the best products that we can. So thank you, Liz.
Thank you very much, Gloria. A joy to work with you. Okay, I'm going to go ahead and show these results.
Okay. And once again, people are paying good attention, and the common name, one of the common names for methamphetamine is crank. Crack and snow are more likely. Crack is a derivative of cocaine. Snow is sometimes used to refer to cocaine, and yellow jackets are sedatives. So there you go. Good job, everybody. And I think we have one more polling question for this topic. What is K2 or spice? Is it cannabis, opiate, stimulating stimulant, or a hallucinogen?
Okay, I'll go ahead and show those results as well.
And once again, correct, it is in the cannabis family. K2 and spice are these newer synthetic drugs that mimic cannabis types of substances. All right, terrific. Thank you. So let's go back to our slides. And before we move on to talk about substance intoxication and withdrawal, let's open up the phone lines and see if anyone has any comments or questions at this point.
Ladies and gentlemen, if you would like to ask a question or make a comment, please press *1 on your touch-tone telephone. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. Again, everyone, that's *1 if you have a question or a comment. We'll pause for just a moment. Ladies, there appear to be no questions at this time.
All right. Everything's clear as a bell. Excellent.
I'm sorry. We did just have one person queue.
Okay.
And caller, your line is open.
This is Martha Gibson from Midtown. What do you know about methcathinone?
Methcathinone. Nothing.
People call it cat, but
oh.
I saw something about a long time ago, but I haven't heard much about it here recently.
Yeah, I have heard of cat too. I don't have any information. If anybody has any information about that drug, can you do *1 and we can hear from you? Because this is a great information sharing time for people who have different resources. Thanks for that question, Martha.
You're welcome.
You always have great questions, Martha.
Poor answers, though.
And we haven't had anyone press *1.
All right. Well, that is something that I will look into. We can have a little bit of follow-up about that. Methcathinone.
We did actually just have Diane Duffy press *1.
Okay, Diane, what do you have?
Oh, hi. I just read in Galanter yesterday. Cat is under the hallucinogen category. It's complex, and I don't think it's a pure hallucinogen, but that's the general class. If you want to read more about it, you can go to a chapter about hallucinogens.
Well, thank you. And there are a lot of great resources out there to learn more about these drugs of abuse. And as I said, if we could get like a physician on here to really talk about the brain specifics, it really is fascinating. Definitely outside the scope of this presentation and my knowledge set, but good stuff. But thank you, Diane, for that answer.
You're welcome.
All right. Anyone else?
And we do have Rosa. Your line is open.
Hi, Rosa.
Hi there. Thanks for that training. Listen, when you did a chart who's using, you said for ages 12 years old and above.
Yes.
Is there a difference between what the 12 to, say, 19 are using versus the older adults?
I did not take a look at those data. I'm not sure. I would think that there might be, but I did not take a look at that.
Okay.
But we did include in the slide set the link to that 144-page report from SAMHSA that breaks things down by age, by ethnicity, by drug type, by part of the country. So if you're interested in those kinds of demographic differences, I definitely encourage you to take a look at that report because there's a lot of interesting information in there.
Great. Thank you.
Yeah, thank you.
And no one else has signaled.
Okay, so let's move on and talk about substance intoxication and withdrawal. So we talked about the different drug classes, and so when you use these drugs, then what happens? This is basically what we're talking about. Now, what happens when you use these drugs? Now, most of the information from this point forward in the presentation comes directly from your DSM-4, which is the Diagnostic and Statistic Manual of Mental Disorders. It was published some time ago. There's a major revision underway for DSM-5. We will talk toward the end of the presentation about what some of the changes are going to be in substance use disorders in DSM-5. But right now, the DSM-4 is your hallmark way to diagnose mental disorders. Substance use disorders are classified in the mental disorders, and the intoxication and withdrawal syndromes are all listed there, as are the abuse and dependence criteria. And what's important to realize is that we're looking at these different drug classes because the drug classes have different impacts and different effects. And so the intoxication and withdrawal syndromes will be different based on the drug class. And again, more information on this, long narrative descriptions of these syndromes can all be found in DSM-4, and most of this information is pulled right out of there because when we do research, it's very important for us to be speaking a common language, that we're all coming from the same perspective, that we're all using the same concepts. And so by looking at the DSM-4, which is our guidebook for diagnosis, we can be sure that we're all talking the same language, and we have some reliability in our assessment of substance use disorders. So according to DSM-4, intoxication consists of a few different items. One is that it's a substance-specific syndrome, say that 5 times fast, due to recent ingestion of a substance. So what does that mean? Basically, this is what happens after you take a drug. And again, it's substance-specific. So what happens when you drink is different than what happens when you use meth. And that's obvious, but we have these more specific guidelines to really flesh out these different syndromes. For intoxication, these are clinically significant and maladaptive behavioral and psychological changes. So if you have a drink and you're doing okay, you may not be intoxicated per se. To meet criteria for intoxication, you have to have some bad things happening to you. Right? Maladaptive behavioral or psychological change means you're doing something that is not good, or you're having some kind of mental change that is also not for the best, or it's some problem for you. There's some kind of clinically significant problem. So again, people may use some of these substances and not really meet criteria for intoxication because they don't meet what's happening doesn't produce some kind of major change in behavior or mental health. And then all of these in DSM-4, whether we're looking at intoxication or any other mental disorder, we always want to make sure that the symptoms that we see are not due to some other mental disorder or some general medical condition. So somebody might look like they're high, but in fact they are getting ready to have a seizure, and they're in that kind of phase before they have a seizure. So we always want to make sure that there's not some medical problem that is actually looking like it's some kind of intoxication effect. I mean, you might have seen people come into your office and you think they're high, but in fact they're having some other kind of issue. So just something to remember. So that's intoxication. You take a drug and you have these effects. For withdrawal, it's really kind of the opposite. It's having some problems after you stop using a drug. And specifically, it's defined as stopping or cutting down on heavy or prolonged substance use. So again, using alcohol as an example, because a lot of people can relate to the experience of having a drink or two. Or let's say you have had a few drinks and the next day you wake up and you're not feeling so well. That's not really withdrawal. And that's a hangover. It's not really withdrawal because we're talking about heavy or prolonged substance use for withdrawal syndrome, not just a one-time deal. So also with DSM-4, most of these problems are really looking at patterns of use or longer-term use, not necessarily intoxication, but for a lot of these things it is. So it's something to keep in mind. Also withdrawal, like with other DSM categories causes clinically significant impairment or distress. And this is a part of every DSM. If you look at depression, if you look at post-traumatic stress disorder, if you look at the other anxiety disorders, there always has to be some kind of clinically significant impairment or distress to meet criteria for a disorder. Same is true with withdrawal. And again, that kind of ruling out a general medical condition or another mental disorder. So those are the general definitions of intoxication and withdrawal. And we're going to get into the specifics of what those syndromes look like for each drug class. So before we do that, let me just open it up one more time and see if there's any general questions about intoxication and withdrawal. So you would press, I believe, *1, Lisa?
Yes, that is *1 if you do have a question or a comment.
About intoxication or withdrawal in general. We're going to get into much greater detail about this in a moment.
Once again, ladies and gentlemen, that is *1. Ladies, no one has signaled.
Okay, so let's just get right into the different drug classes. So let's start with alcohol, and it would be alcohol or sedative intoxication because, as we discussed, alcohol and sedatives are the same drug class. So, what is alcohol intoxication going to look like? Well, when somebody's really drunk, what happens? They may be inappropriately aggressive. They may be kind of hypersexual. They may have mood swings, impaired judgment, or some kind of problems with their social or occupational functioning. If you're really drunk, you might have problems with your with people around you, and you may have trouble getting your work done or even getting to work. Not surprising, but those are the. And remember, we were talking before about the behavioral and psychological consequences. Here they are for alcohol intoxication. And now, here are the more physiological changes that take place with the intoxication and withdrawal syndromes for alcohol and sedatives. And we've set up the presentation for each drug class. We'll look at the intoxication and withdrawal effects on the same slide. Again, in DSM-4, there are some different guidelines for making these diagnoses. For the different drug classes, sometimes you need one symptom, sometimes you need two symptoms, and those, again, are indicated on the slide. So some of the behavioral changes and physiological changes that happen with alcohol and sedative intoxication are slurred speech. Again, when somebody's drunk, you can, hear that slurred speech. They're not very coordinated. They might spill their drink, stumble around. Nystagmus is basically your eyes are kind of, you don't have good control of the muscles around your eyes. And impairment in attention and memory. And if you're really, really, really intoxicated, you can fall into a coma or have some kind of stupor. And alcohol intoxication can be fatal. And especially if people don't know that alcohol and sedatives are the same drug class and take both of them, these are depressants, and they depress the central nervous system and can lead to death. So a stupor or a coma could be one of the later phases of pretty severe alcohol or sedative intoxication. So how about with withdrawal? For alcohol or sedative withdrawal, you would have two or more of the following. And this is also relevant when we start thinking about making a diagnosis of dependence, because withdrawal is one of the substance dependence criteria, and you need to know what the withdrawal symptoms are for a certain substance in order to know whether or not a person meets criteria for withdrawal. We'll talk more about that later, but to know some of these things now can be really helpful. So for alcohol and sedative withdrawal, you have to have two or more of the following. So autonomic hyperactivity is basically you're a little bit on edge. You have the shakes. Your heart might be pounding. Your hands are shaking. There's nausea and vomiting. Hallucinations or illusions for pretty severe alcohol withdrawal. Again, that's for somebody who's probably drinking heavily and prolonged and who stop suddenly. It's the other thing, you don't want people to stop suddenly. We want people to come off of these things gradually. Alcohol withdrawal can be a deadly process if it's not managed correctly, and often it is done in a inpatient detox environment with medications to assist because it can become fatal if it's not done correctly. Also, insomnia, you can't sleep because you're in withdrawal, have anxiety, and people can have seizures as well as a result of alcohol or sedative withdrawal. Okay, so to meet criteria for that, you would need 2 or more of the following. All right, so now we'll talk about heroin and opiates. Again, we know that those go together, which is heroin or prescribed painkillers. All of them are in the same drug class, have the same physiological effects. So when somebody's high on heroin or an opiate, they may have initial euphoria. They feel really happy and good and calm, but then they might get kind of zoned out or not really care about things with apathy. There can be kind of sadness or just not feeling well as a result. People can be agitated or they can be really slowed down. It just kind of depends on what's in the drug and a person's own kind of biochemistry in their state. They can have impaired judgment, of course, and social or impaired social occupational functioning. And you'll see that those 2 often coincide with any intoxication syndrome, which, again, not surprising. So more specifically, for intoxication, you would need some of those on the last slide, as well as 2 or more of the following in the intoxication: constricted pupils, drowsiness or coma, slurred speech, impairment in attention or memory. So that's what happens when somebody's high on heroin. Now, what's also interesting about intoxication and withdrawal is that for a certain drug class, you can look at them and see that each symptom kind of has its flip side in the other syndrome. So for intoxication, for heroin, constricted pupils, right? The pupils are really small. Well, when you're in withdrawal and the drug is coming out of your system, you have dilated pupils. So it's the flip side of that. The other thing that's not in the slide, and which is part of the heroin intoxication, people kind of get really dried out. Their mucous membranes get dried out. Their mouth is dry. That's part of when they're high on the drug. But when they go into withdrawal, and here you see that they need 3 or more symptoms of withdrawal to really meet the syndrome, they go in the opposite direction. They have sweating. They have watery eyes and runny nose. It often has a flu-like quality, the withdrawal syndrome from heroin. Also, people can be very upset. Sad, dysphoria is kind of a catch-all phrase for a bad mood. You can imagine being in a bad mood if you're in heroin withdrawal and you're sick and your muscles are aching and you've got diarrhea. It's not pleasant. That's also the flip side. When people are using heroin, they're constipated, and then when they're withdrawing from it, they have the opposite effect. Also, a lot of yawning and fever. So, the physical symptoms of opiate withdrawal can be very uncomfortable and severe, and this is one of the mechanisms that keeps people using it is to avoid withdrawal, and one of the reasons why it has pretty high addiction potential, because coming off of it can be incredibly unpleasant. All right, so we move on to cocaine and stimulants. And here, again, looking at more of the behavioral and psychological changes related to using cocaine and other stimulants. Well, there's euphoria, again, that kind of excitedness, or there might be more people feel kind of dull. Changes in sociability. People may become much more social, or they may become withdrawn. Hypervigilance is really kind of being on the lookout for things, feeling things may not be going right, maybe getting a little bit paranoid. That could come along with cocaine or stimulant intoxication. People might become overly sensitive in interpersonal situations. They may become more aggressive, easier to become anxious or tense or angered. And again, we have those impairments in judgment and social and occupational functioning, which, again, pretty obvious why. So those are the behavior psychological. Now here are some of the more physiological symptoms of using these drugs. For intoxication, if you have 2 or more, heart racing, dilated pupils, blood pressure changes, chills or perspiration, nausea or vomiting. That, I think, is again, if you're taking a lot of these drugs. People who take a lot of these drugs over time might lose a lot of weight, might get really edgy. Also, people end up having heart attacks. There's a lot of strain on the heart from taking a stimulant. And so there can be some cardiovascular sequelae related to that. I love that word. Don't use sequelae. And then for also confusion, seizures, coma, and once again, those are the more extreme and heavy, prolonged use. Although there have definitely been cases where somebody uses a stimulant once, and it can have some pretty, some pretty severe effects, depending upon the potency of the drug. So some of these happen after prolonged use, but some of them can happen even if somebody just uses once, might use quite a bit, and they have a negative reaction. So for stimulant or cocaine withdrawal, this is one that you have to have dysphoric. You have to have dysphoric mood in order to meet criteria for cocaine withdrawal. There's a beautiful sound going on in the background here. Sorry about that. So the person has to have dysphoric mood plus 2 more symptoms. So they're upset, depressed, anxious, plus fatigued, have bad dreams, trouble sleeping, increased appetite, or some kind of psychomotor agitation. And I'm going to need to put everybody on hold for just a second. I'm in the middle of a webinar. Okay. Sorry about that. Thought I had all things that made noise turned off. All right, so moving along to cannabis. So when somebody has been smoking pot or using some of these synthetic K2 spice types of things, what happens when somebody's high on marijuana? Well, they might have difficulties in their coordination. They may be really happy, or they might be kind of anxious. They may feel like time is slowing down. Again, we have the impaired judgment. And here, notice that there's not the criterion of social or occupational problems, but there is social withdrawal. People might become withdrawn when they're high. And here we have the intoxication withdrawal symptoms. For cannabis, 2 or more, red eyes, increased appetite, might people get the munchies, dry mouth, heart racing. And then I've listed withdrawal symptoms here. If you look in DSM-4, there are no withdrawal symptoms listed for cannabis. When DSM-4 was developed, that was not, people did not believe there was a cannabis withdrawal syndrome. However, over time and with quite a bit of research, it does seem that there is a withdrawal syndrome. So these are the symptoms of withdrawal from cannabis that are proposed for DSM-5. These will most likely be included in the new DSM, which I believe is scheduled for release in 2014. But in the meantime, if you're assessing somebody for withdrawal, these are things that you would want to keep in mind. And again, this would be on a protocol-by-protocol basis. If your protocol team wants you to assess cannabis withdrawal, which might be a good idea at this point since we are going to be moving into a new diagnostic system, which will include this, these are the things you would look for when people stop or cut down on heavy use of cannabis. So that would be irritability, anger, anxiety, problems sleeping. That's one of the main ones. That is like the most commonly reported symptom of cannabis withdrawal is insomnia. Also decreased appetite or weight loss, some restlessness, depressed mood, and then at least one of those following physical symptoms that you see listed in that last box. And you see again the opposite effects of intoxication and withdrawal, right? Increased appetite versus decreased appetite. Well, there's the one anyway. Okay, so there's cannabis for you. And just breaking news on the possibility, the inclusion of withdrawal in DSM-5. So we move on to hallucinogen intoxication. And here again, the psychological and behavior changes could be anxiety or depression. Now this is right when people take LSD or mushrooms or ecstasy. Ideas of reference. People are talking about me. People are looking at me. Kind of some paranoid ideation. People are afraid they're losing their minds. There's a real loss of control, a real sense of loss of control when people are high on hallucinogens. And again, we've got those impaired judgment and social and occupational functioning. It's hard to imagine somebody high on LSD working well at their job, but I guess it depends what it is. And so again, the physical symptoms of hallucinogen intoxication would be two or more of either dilated pupils, tachycardia, which heart racing, sweating, palpitations, blurred vision, tremors, problems with coordination. And here you notice that withdrawal is blank. There again, in DSM-4, there are no symptoms of withdrawal listed for hallucinogens, but there is another category altogether for when people stop using hallucinogens. And we commonly think, and this is kind of hyped up in the media, especially when you think about people in the 60s and the 70s using LSD. The big thing that people would talk about afterwards were having flashbacks. It could be months and months later, and some people report years and years later, and all of a sudden they'll be sitting somewhere and they feel like they're tripping on acid. And so there's actually a syndrome for that listed in DSM-4, and it's called hallucinogen persisting perception disorder. So the perceptions persist, right? Flashbacks, what we commonly know as flashbacks. And they're mostly perceptual flashbacks. And this could either be somebody sitting there and suddenly they just see a flash of color out of nowhere, maybe image trails, halos around objects, or other false perceptions. So while there is no withdrawal syndrome from hallucinogens, there is this other flashback type of disorder that's in DSM-4. I've never worked on a trial where we've tracked anything like that, and often, especially now in the CTN, as we try to make our assessments more and more time efficient and less burdensome for our clients, we are not assessing a lot of these substances as a matter of course. When we started, we would ask for all of the substances. We would ask lifetime histories of everything you ever used. Some of those interviews in and of themselves would take 2 or 3 hours for people who, if you're assessing the symptoms of dependence and abuse for somebody who has used every single substance in their lifetime, that can take a really long time. Believe me, I've done a lot of those interviews. But now in the CTN, we are really moving toward decreasing that kind of burden and asking questions that we're really most interested in. We used to collect a lot of data, and no one ever looked at it. And we're just much better these days at only collecting the data we need, again, to decrease that response burden on the participants and focus our data collection efforts. So in your experience of working in the CTN, you may never ask about these drugs. However, it's really important to have a good broad knowledge of substances of abuse if you're working in this field. So there's my little digression on my soapbox, and back we go. So now we're going to talk about inhalant intoxication. Again, not commonly used, but not commonly assessed, unless somebody says, yeah, that's my primary drug of abuse. So somebody is, and here you've got these pictures of glue and spray paint. Now you can't buy spray. I don't know if this is true in every state. Certainly in some states you can't buy spray paint if you're over 18. It's all locked up behind bars, basically, because of the abuse liability of inhalants, especially in kids and teens. And Rosa, you asked the question, are there differences in drug use in by age? And I'm sure inhalants would be one of the differences, certainly. So when somebody is using inhalants, they can be belligerent, assaultive. They can kind of not care what's going on. And again, problems with judgment. I mean, you could say there's problems with judgment even using inhalants. And then impaired social and occupational functioning, not surprising. Again, no withdrawal syndrome for this, but a lot of different kind of physical intoxication symptoms that you have to have a couple of. Dizzy, kind of depressed reflexes. People become almost paralyzed sometimes, but because of what happens to your brain after using inhalants. They're highly toxic, and so sure, you get high, but the high is this very kind of nasty physical high that really gets right in there. Muscle weakness, blurred vision. I guess they get enough euphoria that it keeps people coming back. So that's inhalants. And we would be remiss if we did not talk at least a little bit about nicotine. And we are starting to assess, we didn't always assess nicotine dependence. Now, obviously, smoking and other substance use, there's a high correlation between those things. And we haven't, and if you work in a substance abuse treatment program, you know that a lot of your clients smoke. We've done some nicotine studies. We've done some smoking cessation studies in the CTN. I believe there's one going on now. But we haven't assessed nicotine across the board in a systematic way. We're starting to do that more in the CTN, which is great. There is no nicotine intoxication listed in DSM-4. There's really no intoxication syndrome for nicotine. But the problem with nicotine is that there's a pretty substantial withdrawal syndrome, which is one of the reasons, like I mentioned with heroin, why it's hard for people to stop, because it's such a negative experience stopping using the drug or stopping smoking that people tend not to or need a lot of help in order to do so. And if you've known anybody or if you yourself have had the experience of stopping smoking or trying to stop smoking, these will all look very familiar to you, and I'm sure that there are a number of people on the phone who have experienced this firsthand. When you stop or cut down on smoking, you get a lot of irritability, frustration, or anger. Or if you're a spouse or a partner of somebody who stopped, you can speak to these, I'm sure. Being in a bad mood, not being able to sleep, being anxious, having trouble concentrating, increased appetite or weight gain, restlessness. Again, quite unpleasant, but one of the reasons why it's very hard to stop. So there's nicotine withdrawal as demonstrated in DSM-4. So before we open up for questions, we're going to do our game show today. It looks like we have some. I don't know how to use the Q&A thing. It says we have 3, but I don't know what that means. So what we're going to do our little game show. Name that high. I'm going to name that tune. Well, we're going to give you a little scenario and see if you can name what drug the person has been using. Okay? So let me try to drive this, Liz.
I've lost connection again.
Oh, well, good thing I'm connected.
Okay. As soon as I get on, I'll do the questions.
All right. Looks like some people, we had this up before. Okay, Brian is the life of the party. He's talking to everybody, excitedly explaining about his new business venture. He seems a bit on edge and was seen arguing with a man by the bar. Brian may be high on alcohol, heroin, cocaine, or hallucinogens. So the polls are open, I think, and you may vote. Oh, it says polls are closed. Liz?
Just hover over top of the icons right there, and one will, you'll get a little bubble that tells you polls are open.
I'm hovering. I'm not sure what I'm supposed to hover over.
Go about 3 over to the right, and it should be ready for you there.
Nope.
Okay. Try another question and see if that's open for you.
Okay. So we have, can people see the results of that question?
You have to show the results.
It says results are hidden. Yeah, I don't know how to drive these polling questions at all.
Okay, so if you go over to the next polling question, just click on that polling question.
Okay.
And that one should be open. Typically
Yeah.
they are open.
Oh, good. Okay. A participant comes into your office for an interview. She says she thinks she has the flu. Her eyes are watering and nose is running. She has the chills and is nauseous. She may have the flu. She may also be experiencing hallucinogen intoxication, heroin withdrawal, cannabis intoxication, or alcohol withdrawal. All right.
Now, if you hover over about the first icon you see at the bottom, Gloria, you can click on that and it'll show the results.
The first icon I see at the bottom. Oh. I'm just clicking on things. Here we go. Results are hidden. Polls are open. Polls are closed.
And then right next to that should be reveal results.
I have edit poll. No. Sure you want to clear the results? No. Yeah, this is one thing we really... Oh, results are shown.
There you go.
Are they?
They're shown. I don't see it. If you click on that, so for everybody else, just go over the results.
Okay. Well, we have 25 people who said heroin withdrawal. 100% correct. Good job. You're paying attention to that part about the flu. Good job. All right. So, welcome to my learning curve as we go along. And here's the last polling question. You come home from work and your daughter's on the couch watching TV. When you try to talk to her, she's not very responsive. She's speaking slowly, her eyes are red, and she's got empty boxes of crackers and cookies around her. What might be going on? For 1, she's premenstrual. 2, she's been smoking pot. 3, she's drunk. Or she's withdrawing from cocaine. What could it be?
I apologize, Gloria. I'm heavy at work here trying to get reconnected.
I jump in when I can. All right, and let's see if I can reveal the results. No, I'm editing the poll again. Uh-oh.
Should be the first little icon that's on the far left.
On the far. Results are shown. Look at that. And 96% of you said she's been smoking pot. I was also thinking she might be premenstrual, but that is not the topic of our talk today. So that's probably the one that's most likely based on that vignette. Okay. I know these were not the most challenging, but something to break up our day. All right. So before we move on, I think that was our last one. Yes.
Mm-hmm.
So
go back to Brian.
Let's go back. No. Oh, we could go back. We could go back to Brian now that I know what I'm doing. Okay, so let's. Polls are open. Okay, Brian. Brian is, let's go back to Brian. So what's going on with Brian? He's the life of the party. He's talking to everybody. He's talking about his new business venture. He's a little on edge. What might be going on with Brian? Alcohol, heroin, cocaine, hallucinogens. All right, I'm going to go ahead and reveal the results, I think. Yes. All right, so we have most people, 76% of people saying high on cocaine. About 18% of you said he has been drinking, which there's definitely some overlap here. See, I didn't close the polls.
That's okay.
Okay, but it's good. It's all good. It doesn't change our results that much. It could be that he's been drinking. The vignette is really, he's a little too, he might be a little more sociable. It sounds a little bit like he's pretty goal-directed, explaining about his new business venture. He's got a lot of energy. Most likely high on cocaine. There is a bar there. He is arguing with somebody around it. He could also be have been drinking. That could also be the case, but most likely high on cocaine. So good job. Everybody's got a pretty good sense. And a lot of this, right, you've seen people who've been intoxicated using substances. Most likely, and most people have seen somebody who's definitely drunk. If you're new to substance abuse treatment, you may not have seen other people intoxicated in other ways. And people are in treatment, they may come in intoxicated, and it will serve you well to be able to understand what's going on with somebody when they come in your office and they seem altered in some way. All right, so this is a good time to open up the phone lines and see if people have questions about all of that. Oh, the other thing we were going to do, actually, let's go ahead and open up the phone lines, and then we'll show you this other great tool that you can use.
And once again, ladies and gentlemen, it's star one if you have a question or a comment. Star one to have your line open. We'll pause for just a moment.
While we're waiting for questions, I'm going to just bring up this web page.
And we do have a question from Cindy.
Okay, Cindy.
Hi, this is Cindy. Just have a comment on about alcohol.
Yeah.
Because alcohol is initially a stimulant and then becomes a depressant. So, for that reason, in the beginning, it could be Brian could be drinking alcohol. If years due to that.
Yeah, and people can become kind of disinhibited and right, kind of excited, life of the party, and then crash. Mm-hmm. Yeah, absolutely. Thank you for bringing that up. And I think both of those sides of that are represented in the alcohol intoxication criteria too. So that's another reason, that there's that overlap for Brian. Thank you.
Mm-hmm.
Now, what I just brought up here, I'll take another question, that's fine, but I just wanted to show you, this is on the NIDA website. If you haven't visited the NIDA website, please do. There's tons of great resources there, above and beyond LiveLink, right? But here we have a list of commonly abused drugs, and it's the category name, examples of street names. So I gave you some examples of street names. There are many more. Here's a great list that you can use to see other street names and commercial names that people use. Also gives you how these drugs are mostly administered. We didn't talk about route of administration. You assess that on a number of different assessment tools that we use in the CTN, but that's listed here. And then also in the far right-hand column, there are the intoxication effects and potential health consequences of each drug class. So for more information on these, we want to give you an introduction to these topics, but also some resources for more information. This is a great tool to have at your at your fingertips when you're doing assessments, and you need to figure out what a drug class is that somebody says off the top of your head you just don't know. So it's a good tool. And we have other tools like that, like if you're using the CD, which is to get the diagnosis of dependence or abuse, etc. Okay? So any other questions?
And there are no further questions at this time.
All right. Okay, so now we know all about what the intoxication syndromes look like for different drug classes, what the withdrawal syndromes look like for different drug classes. We've seen how they can cause psychological changes, behavioral changes, and physical changes that can be problematic for people. But another thing that we want to look at, and which we often assess in substance in our studies, is the difference between substance abuse and dependence. And here's a fun little cartoon that Liz found. I'll bug you about your catnip. Don't bug me about my martinis. So let's talk about substance abuse versus substance dependence. These are two different diagnoses. They are substance specific. So you can meet criteria for heroin abuse, usually meet criteria for heroin dependence, but alcohol abuse, heroin dependence. So we diagnose them substance by substance. And one handy way of thinking of the difference between these two diagnostic categories is that substance abuse is really the consequences related to use, and we'll see what those consequences are. There's 4 specific ones in the DSM-4, versus substance dependence. And substance dependence can be looked at as 2 different areas, one being the physiological symptoms of dependence, specifically tolerance and withdrawal. We already know a lot about withdrawal. And then loss of control. So when people have lost control over their substance use, those are the items that we see representing substance dependence. And we'll look specifically at each one of those criteria. So let's start with the DSM-4 criteria for substance abuse. So the first is that it's a maladaptive pattern. Again, it doesn't just happen once or twice. It's a pattern, right? It's maladaptive. It does not serve the person well. Of substance use, which leads to clinically significant impairment or distress. Here we go again, impairment or distress, as manifested by one or more of the following occurring within a 12-month period. And I mentioned before that impairment or distress is always a part of the DSM criteria, always a part. And so this is where impairment and distress is reflected in substance abuse. So within a 12-month period, you have to have one of these things as a result of using a substance for a while, having kind of a pattern. So the first area, and remember I said, let's think about substance abuse as the consequences related to use. So the first one is a failure to fulfill major role obligations. So what does that mean? That recurrent substance use results in not being able to go to work, go to school, take care of things at home, take care of your kids. So it's really that kind of consequence related to your role obligations and what you're supposed to be doing on a day-to-day basis. Okay, you can see how that could relate to students, how it could relate to people who are working or people who are homemakers who are supposed to be taking care of their house. So there's different ways to meet that criteria. The second potential consequence related to your substance use is that you're using it in dangerous situations. The classic example here is drinking or driving. But as you're assessing this criterion, don't forget, not everybody drives. How about riding a bike? I was in Portland 2 weeks ago. Those people ride their bikes. They are vehicles. They're not just out for a joyride. People are riding their bikes to get from point A to point B. If they're intoxicated, I already felt like I was walking in the middle of the road, walking on a pedestrian path. So riding a bike when intoxicated can be extremely dangerous. Going swimming after you've been using can be extremely dangerous. I've interviewed construction workers who drink on the job and then go up to the 50th floor of a building and are doing metal work, on the frame of a building. These are all examples of substance use in dangerous situations. It's not just drinking and driving or drinking and riding a bike if you're in Portland. It was amazing to me. All right. The third reason, or the third consequence as a result of substance use, which is in the substance abuse category, are legal problems. This would be, again, recurrent substance-related legal problems, like arrests. Like if Brian gets in a fight at that party and he gets arrested, that would be a substance-related legal problem. Here again, though, we're talking about recurrent. So if that only happened once in the past year, probably wouldn't meet that criterion. If he'd been stopped by the police, disorderly conduct, then that would be. Now, what if people are, most people, if they're using illegal drugs, they are doing something illegal. If they didn't have any problems related to that, then this would not be met. So if you're using drugs that don't have any brushes with the law, then you really don't have any legal problems. You may disagree with that personally, but in diagnosing this criterion, that's the spirit of this criterion. And the fourth manifestation of substance abuse is continued use despite having social problems. So somebody is drinking, they're always having fights with their partner, significant other, and they continue using anyway, and they just continue to use. So even though they're having these problems, it doesn't affect their substance use at all. So those are the four criteria for substance abuse. And this is very important. You cannot meet substance abuse if you've ever met criteria for substance dependence. So it's a hierarchical model of diagnosis. Basically, dependence always trumps abuse. Dependence is the more significant syndrome. So once you meet dependence, you don't even have to assess abuse. And some of the scales and assessments that we use actually will skip people out of the section if we know that somebody has already met dependence. We don't need to assess abuse because it's no longer relevant. All right, so we have finished talking about substance abuse. Let's go ahead and open the phone lines and see if anybody has any questions about substance abuse.
Once again, ladies and gentlemen, it's *1 if you have a question or a comment.
Any specific examples you have questions about? Any comments about Portland? I loved Portland. I loved it. The bicycle riders made me a little nervous.
And we do have a question. It comes from Paul.
Okay, Paul.
Yes, hi. This is Paul Joaquin with NIDA.
Hi, Paul.
Hi. So it's like a severity. I mean, you were saying if you have dependence, you automatically have abuse. I'm trying to understand why is there those two categories, dependence and abuse, to begin with? What's the logic behind having these two? I mean, one seems like a practical life problems, that's abuse, and dependence is more of a physiological thing.
Well, I think that was the thinking when these categories were developed. I'm going to say for DSM-3. I think for DSM-3, the abuse dependence categorization came up. So abuse, again, was more like these life consequences related to your use. When you look at dependence, then when we get into the dependence criteria, you're going to see it's more that you're no longer able to control your use. You've got these problems that are result. Yes, they're affecting your life, but it's also loss of control. So we do have the physiological symptoms, but then some other items that reflect more of a loss of control. And it's not that if you meet dependence, you automatically meet abuse. It's that you will not have an abuse diagnosis if you have met dependence. So abuse no longer gets diagnosed. Like you would not have a concurrent diagnosis of substance abuse and substance dependence. It does become almost like a severity thing, but they talk about it more of a hierarchy, not so much of severity.
Thank you.
Welcome. Thank you for the question.
So, Gloria, I was able to get into the Q&A, and we have a question about piloerection. Do you want to tell everybody what that is?
Oh my gosh, that's one of my favorite words. That's when your hair stands up on end. How do you like that? It's a fancy way of saying that your hair is standing up on end. I'm so glad somebody caught that and asked. We were going to put that as a polling question, but I'm glad you asked. Yeah, that's basically your hair standing up.
Yeah, it takes care of all the questions that were in the prompt.
Okay, good. Any other questions?
There are no further questions on the phone as well.
Okay, thank you. All right, so let's go on and talk about substance dependence. And, Paul, we're going to get back to your question about, keeping these criteria separate and these diagnoses separate, and what's the validity of that or the reasoning behind that, and what DSM-5 is looking at doing because of a bunch of research that's been done in the field over the past 15 years. All right, so now let's talk about substance dependence. Substance dependence is another maladaptive pattern of substance use leading to significant impairment and distress and manifested by 3 or more of the following occurring in the same 12-month period. So you're looking at about a year of time, and people have 3 or more of the following symptoms, and there are 7 in total, okay, 3 of 7 substance dependent symptoms. So first I've listed the physiological symptoms, and the first physiological symptom of dependence is tolerance. And tolerance can be achieved by one or of 2 ways. Either you need a lot more of a substance to get high or feel the effect, or a lot less. You have much less of an effect with the same amount. So people who have been using a long time develop tolerance to a drug. They need a lot more. So when you talk to people and you assess their substance use over time, people will say, yeah, when I started using heroin, I could use 1 bag and it would get me high. Now I have to use at least 5 bags of heroin to get the same high from when I started using regularly. And we want to assess from when they started using regularly. So having kind of a pattern of use. Same with drinking. I mean, some people can drink their whole lives, have 1 or 2 drinks, and that's it. Other people, maybe they started, they would have a couple of drinks, a couple of beers would get them the buzz they wanted. And then over time they needed a 6-pack to achieve that same thing. I've interviewed plenty of people who will customarily drink a case of beer to get the same effect that they used to get from drinking 2 beers. Now, this could take place over many years. It could take place quickly because it depends on the drug, but that's the spirit of tolerance, is that it's the effect of the drug becomes less over time. And it can be met in either of those 2 ways. So that's a physiological symptom, tolerance. And then the other, which we've already spent a lot of time talking about, is withdrawal. So with withdrawal is either the characteristic withdrawal symptom, which we know for each substance inside and out already, or the other way that you can meet criteria for withdrawal is that you take a substance or a closely related substance to either get over the withdrawal or avoid having it altogether. So like I was mentioning before, people will continue taking that same amount of heroin because they don't want to get those withdrawal symptoms because they're awful. Or they may take methadone, right? That's one of the treatment for substance use, for heroin use, for opiate use. And that relieves their withdrawal. So they're taking some other substance. Alcohol and sedatives, we know that they are closely related substances. We know that they are in the same drug class, so this would work for that as well. Okay? So it's either you have the withdrawal syndrome or you don't have it because you're using something else. One thing that trips people up when they're assessing withdrawal, because you'll ask people this question, have you ever taken the same or related substance to relieve or avoid withdrawal or to avoid having those uncomfortable symptoms related to stopping using the drug. And so you're asking somebody about their heroin withdrawal, they say, yeah, I'll take some Valium, and that'll help. So that is not that criterion, because as we know, Valium is not in the same drug class as heroin or as an opiate. Valium might help a little, take the edge off. Valium might help somebody who's in cocaine withdrawal. They feel less of their withdrawal symptoms, but it's not avoiding or relieving their withdrawal symptoms by taking the same or closely related substance. So you need to know these technical, this is one of the reasons why we have this webinar today, because there are reasons to know these technical similarities and differences between the drug class, because it may or may not then result in somebody meeting the criterion for dependence. Okay? So tolerance and withdrawal. These are hallmark symptoms, physiological symptoms of dependence, and so let's open up the phone lines and see if anybody has any questions about this, because some people find this tricky.
And just a reminder, ladies and gentlemen, that is *1 if you have a question or a comment. And we'll take a question from Mariel.
Hi, it's Mary Ellen.
Hi.
I'm a little confused about having to take the same class of compound.
Uh-huh.
And you said it was tricky, and I think it's tricky, because they're having a characteristic withdrawal syndrome. And if they didn't take anything, then you could classify it as dependence based on that.
So, right, you could meet withdrawal if you have the withdrawal syndrome, right? If you just have that characteristic withdrawal syndrome, yes, you meet that criterion for withdrawal. Or, right, you've taken something related. But some people will say that their withdrawal wasn't so bad because, like, their heroin withdrawal wasn't so bad because they took the Valium. When in fact that doesn't really work that way, or that wouldn't meet criteria for withdrawal.
Right. So that's what's confusing me. If they just didn't do anything and they had this withdrawal syndrome, then you would say, okay, dependence.
Yeah.
But if they mitigated the symptom by taking another substance, you wouldn't classify it as dependence, which seems...
Well, you wouldn't classify it as withdrawal, and you wouldn't classify it as withdrawal for that person, for that drug class. Now, it may not be as relevant. I'm using heroin as an example. It may not be as relevant for heroin. It may be more relevant for something like cocaine. But also, let's remember that we're looking at 3 of 7. And if somebody has dependence, they're going to meet it somewhere else. So if you just miss on one criterion, often you know, it's not something to be that concerned about, because if somebody has dependence, they'll end up racking them up somewhere else. But this is, for the physiological characteristics, this is what we want to pay attention to, is that level of detail, which, as you've acknowledged, can be kind of tricky.
Okay, thanks.
Thank you.
And we do have another question. Caller, your line is open.
Hello. My question is this. From what I understand is, when it comes to withdrawal syndrome for substance abuse, if a person is going through withdrawals for heroin, as you used as an example, and they take, say they take a pill to lessen the effects of the withdrawal, you don't classify it as abuse. Is classified in regard to avoidance. Does that make sense?
Okay, so withdrawal, right, the withdrawal symptoms, first of all, are part of the dependence criteria. So we have substance abuse, which were those consequences related to use, and then we have substance dependence. Withdrawal falls under substance dependence.
Okay.
Okay, so if somebody is taking, so if they're taking a pill, to relieve their withdrawal, it's important to know what kind of pill they're taking. If they're taking a painkiller like Vicodin or Dilaudid or Percocet that they're able to get a hold of to ease their withdrawal from heroin, absolutely, that is a withdrawal. That is withdrawal from heroin.
Okay.
If they're taking Valium or Seconal or Xanax and they find that it helps them a little, that's not the same thing because it has to be the same or closely related substance. So when people end up using buprenorphine and methadone, they still have withdrawal symptoms. They still have a withdrawal syndrome. It's just being medicated by the other drug.
Okay.
But it has to be the same drug class, and that's the important takeaway here. It has to be the same drug class in order for it to really meet the spirit of withdrawal.
Okay.
Great question, Carl. And I like the way you asked the question about the pill, because then that becomes the next question: is what kind of pill is it?
Yes. Thank you.
Thank you.
And once again, it is star one if you have a question or a comment. And ladies on the phone lines, there are no further questions at this time.
Thank you. All right, so those are the two physiological symptoms of withdrawal, of dependence. So now let's move on to those other 5 symptoms that you can think of as I've lost control of my ability to deal with. I've lost the ability to control my substance use. So the next criterion: the substance is taken in larger amounts or over a longer period of time than was intended. So I was only going to go and have a drink with a friend after work, and I ended up staying there for 3 hours and having 4 cocktails. I had no intention of doing that. I didn't want to do that, and I stayed and drank anyway. I was going to a party. I was just going to use, I had a little bit of cocaine. I was just going to use a little bit of cocaine. I ended up using the whole gram instead, right? I'm not able to control the amount that I'm using or for the amount of time that I'm using it, okay? So substances taken in larger amounts or over a longer period of time than was intended. You can see how that's a problem controlling substance use. Another criterion, you have a persistent desire or unsuccessful efforts to cut down or control your use. Explicitly here about a problem controlling your use. So you really want to cut down, but you're not able to. This is a very common experience that people report when they come into treatment. I keep trying to stop and I can't stop, right? And they don't even have to be using anymore to meet this criterion, by the way, right? You can still have a really strong desire to control your use. You may not be using, and then you end up using again. So it can be part of a process or a pattern. Okay, so this is unsuccessful efforts to cut down or control, or a persistent desire to cut down or control your substance use. Another manifestation of dependence is that you end up spending a lot of time in these activities. So time spent in activities either getting a substance, so people will tell you that they've visited a bunch of doctors to get prescriptions, or they've driven 4 hours to cop drugs. So a lot of time spent doing that, or in using substances or recovering from their effects. So here it's getting a substance, using it, actually the process of using, or even recovery or withdrawal symptoms. So a lot of your time is spent in substance-related activities. It's kind of taken over your life. Important social, occupational, or recreational activities are given up or reduced because of substance use. And it's not just that, remember in substance abuse there was like an impairment, like you're not able to keep up with the things that you're supposed to do, your role obligations. Here it's it's more either social, occupational, and recreational activities given up or reduced, that your substance use becomes really the focus of everything you're doing, and a lot of other things are falling by the wayside. You used to like to work out, you don't work out anymore. You used to hang out with these certain people, you can't do that anymore because you're now hanging out with your drug friends. Those kinds of problems related to substance use. That's dependence. Giving up hobbies that you like to do. Continued use despite having a physical or psychological problem. And there's a couple of different elements of this. Hold on a minute, please. Clearly talking for too long. So, this criterion has a number of different elements. You need to continue to use even though you have some kind of physical problem or psychological problem that's been caused or made worse by your substance use. But you have to know that the two are related. So, like I have this hacking cough related to allergies. If I were a smoker and I kept smoking, I could say, well, it's just related to my allergies. It's not related to my smoking. Now, that might be denial, but I haven't made that connection. If my doctor, the next time I go, says, listen, you're on the verge of emphysema, you need to stop smoking, now that connection has been made for me. If I continue to smoke despite knowing that my smoking is making my lungs worse, then I would meet criteria for this. This is common when people are diagnosed with like a liver problem as a result of long-term alcohol use. They're drinking, they have this liver problem, they don't know about it, they finally get it diagnosed. Often when they go for treatment, they get a diagnosis that they have some kind of abnormal liver test. They keep drinking anyway. They're continuing to use despite knowing that a physical problem is being caused or made worse by their substance use. Now, you can get this criterion that way for a physical problem, or you can get it for a psychological problem. So, I've been really depressed. The cocaine makes me feel better, but then I know when I come down from it, I crash and I get really much more depressed, but I can't stop using, and I've made that connection. Continued use despite knowing that the drug is causing or making worse a psychological problem. Okay, so those are our criteria of substance dependence. And as I mentioned, it's 3 or more of the 7, and you can see how they're different. As Paul was mentioning, they are definitely different. One is a consequence and one is more of a loss of control. So let's open up again and see if people have questions.
And just a reminder, that's *1 if you have a question or a comment. We do have a question from Melissa.
Hi, Melissa.
Hi. I just wondered if you could speak to the difference in language between dependence and addiction. And I would imagine you're going with the word dependence because that's what the DSM-4 uses currently.
Yes, exactly. Okay. Why.
And
that's the common language.
Okay.
And that's why we're using it.
Okay.
Exactly. Addictions and let me see. And it's an interesting question because I think this issue is getting addressed in DSM-5 because they found that dependence and abuse are not quite descriptive of what is going on. That people think of dependence more, and especially medical doctors, when people go into a doctor's office, or they think more of dependence as a physiological problem. And so there's going to be a shift in DSM-5 toward using the nomenclature of addiction.
Okay, great.
Yeah, thanks for asking that.
Thank you.
It's foreshadowing of my next bits of information. Other questions about our current criteria for dependence and abuse?
And at this time, no one else has signaled, but again, it's star one if you have a question or a comment.
All right. Well, feel free to star one as we go along, but we're just going to kind of drive things home here. So there are some changes. So people have some questions like how are abuse and dependence related? Are there severity differences between the two? Why do we have this conceptual difference between them? Why are they separate? Well, research now is showing over the past 15 years or so, as we've developed more information about the diagnostic system, that maybe this is not the best way of classifying these disorders. And so DSM-5 is actually going to develop a new category, which is going to be called addiction and related disorders. So, as Melissa was just suggesting, we're going to now be looking at these issues in terms of overall addiction and other related disorders. There will be no more distinction between abuse and dependence. Now, until this is published, we will still be distinguishing between abuse and dependence because that's the manual. That right now is our diagnostic Bible. That's the way we have to do it, so we're all speaking the same language. But just so that you know, down the road, there is no difference between dependence and abuse. They are all going to be categorized under the same addiction-type related disorder. And then, if there's withdrawal or tolerance, these will be indicators of physiological dependence, which will be like a subtype of the addictive disorder. Also, this category is going to include non-substance related disorders that have kind of an addictive quality to them, like gambling and internet addiction. So those are going to be now put into the addiction and related, those are the related disorders. So I believe there are 11 symptoms proposed for DSM-5. All you need is 2 or more to meet a diagnosis of a substance-related disorder. They're adding a criterion for craving or strong desire or urge to use. Craving is in the international classification of diseases, and it is a pretty robust predictor of problems with substances, so that is getting integrated. And then there will be severity specifiers that are going to be used probably more reliably than they are now. There's some severity specifiers in DSM-4, but here you would indicate if somebody has a moderate addictive disorder, which would be 2 to 3 symptoms, and 4 or more would be considered severe. So there are going to be some substantial changes. Mostly those abuse and dependence criteria that we've reviewed, they mainly stay the same, but they're all now part of the same category, and there will be no longer any distinction between abuse and dependence, which is probably going to be, it's a more valid indicator of people's problems, that it's just, they're all kind of up for grabs. So that's DSM-5. And then, we have many different ways to evaluate substance use, abuse, and dependence. In the CTN, we use the objective measures mostly of urine and breath tests. We don't use hair as much. We don't use blood. They tend to be more costly and a little more difficult. Obviously, the blood draws take a lot more training of staff to obtain. But we can look at people's substance use objectively by testing these objective methods. And more commonly, and also in conjunction with the objective measures, we use assessments where we ask people about their substance use. And the ones that we commonly use in the CTN is this alphabet soup that I've put here. The Addiction Severity Index is the ASI. The ASI does not give you any kind of information on abuse and dependence. It's not a diagnostic measure. It's really looking at problems related to substance use and the need for treatment in different areas of life related to substance use: family, social, medical, psychiatric. But one area that the ASI we use pretty commonly is the alcohol and drug section, which gives a very thorough assessment of 30-day and reliable. We have a lot of data on the ASI assessment of substance use in the past 30 days in a person's lifetime. So when we look at the ASI in the context of this topic of Drug Abuse 101, it would really be mainly looking at the alcohol and drug section of the ASI to collect the use data that we know is quite reliable and valid. The TLFB is the timeline follow back, and a lot of protocols are using that right now. It's a day-to-day reconstruction of people's substance use using detailed calendars and milestone events in their life. That assessment in most CTN trials is used for 30 to 60 to 90 days prior to baseline, and then over the course of a study to look at day-to-day substance use. But the timeline follow-back has been shown to be reliable in collecting day-to-day substance use data for up to 2 years. So it's a pretty robust measure of getting that substance use data. And when we're looking at substance abuse and dependence, some of the common strategies we use in the CTN are the CD, which is the Composite International Diagnostic Interview. It gives you it's a fully structured interview that can give you diagnoses of abuse and dependence. The SCID, which is a semi-structured diagnostic interview, which hasn't been used in the CTN for a while. The DSM-4 checklist is currently being used in some studies. That, again, is a semi-structured measure that really focuses on the DSM-4 criteria for abuse and dependence. And there are other measures as well, but these are the big ones that are used in the CTN, or that you might most commonly have heard of. So we are just about finished with all that we were planning to present today. So let's open up one more time for other remaining questions, comments.
And once again, everyone, that's star one if you have a question or a comment. We do have a question. It comes from Mariel.
Hi, it's Mary Ellen again.
Hi.
For the assessment, the ASI, the TF, timeline, follow-back, CD, et cetera, they're also used in practice, or are they more research?
That's a great question. The ASI is used in practice, and the ASI is mandated by some states for their substance abuse treatment programs that people have to use the ASI to help inform the treatment plan. The others are more research-based assessments, but the ASI is definitely used in clinical practice and as a clinical tool to help identify what areas are in most need of treatment in people who are coming into substance use treatment programs. Yeah.
And can I sneak in another question? For the ASI that's used in treatment, is it used both to set up a treatment plan and to then assess how things are going, or is it more of a...
I think it is also used for outcomes. I think it's state by state. There are some different guidelines on that, but I'm not, I couldn't tell you off the top of my head. But I think they do use it for outcomes as well as treatment planning.
Thanks.
Sure.
Once again, that's star one if you have a question or a comment.
So, Gloria, while we're waiting for other questions, I can go ahead and let everybody know that this is a recorded session, and it will be available on both LiveLink under the CCC training section and on the CTN dissemination library. And they are provided for your use and for sharing.
Definitely. And we have provided other resources, other links to resources that can be really helpful to you this is really Drug Abuse 101. It is a kind of a survey of the topic, and there's definitely a lot more to learn and understand, but we do hope that this was a good jumping off point, especially for people who may be new to the field.
And ladies, we do have a phone question from Paul.
Okay.
Hi, this is Paul Joaquin with NIDA. This is kind of a tricky question, but I'm going to ask it anyways. So if you're doing research and you want to, see if treatment A is better than treatment B, you've got on this slide urine, hair, breath test, ASI, all those, instruments. Which one would you use to compare treatment A versus treatment B?
Well, personally, I would like to get a combination of an objective measure and a self-report measure. So I think that the common approach that we use in the CTN is to get some kind of biological measure like a urine test and then to be confirmed by self-report, or self-report confirmed by urine. So we typically get both kinds of data, and then we can look and see at the reliability and validity. Usually the objective measure is more reliable, but we also like to hear from the person what their experience is, and especially over time, it's good to get a sense of what. I'm a psychologist, so I like to hear people's stories. So I like to get both of those. Some people might say all you need is the objective measure. All you need is the urine test to know, are they positive at the beginning? Are they positive at the end? And is your treatment working? Personally, I think that's too reductionistic because our treatments are not that cut and dry either. I think we need to be looking at reductions in use as good as possible outcomes in our studies, not just clean or not clean. So that's my opinion anyway.
Thank you.
You're welcome. Do you have an opinion on that you want to share?
Well, we had a task force that looked at that, and that was actually the recommendation, and it was approved by the steering committee, and which is a urine test corroborated with self-report, or I guess self-report corroborated with the urine test. So that was the answer the expert within the CTN who were on the task force came up with. And I was just curious about your opinion.
Yeah, okay. Thanks.
Thank you.
And ladies, there are no further questions at this time.
All right. Well, then, here we go. You know where if you didn't know, you now know where to access information on the CTN Dissemination Library. Also on LiveLink, there are numerous recordings of various webinars that have been conducted in the CTN, and a lot of great resources out there for you to learn more. Feel free to contact me directly. I'm in the CTN directory if you would like to ask any further questions down the line. And thank you all for being here today.
Gloria, I want to thank you for joining and being so tolerant of my inability to stay connected to the Internet. You were quite a trooper about that. And I'd like to encourage anybody else, if you have any questions, I'm going to send out a post-training survey to everybody. And if you are definitely interested in some of the effects of drugs on the brain, put that in the survey, and I'll use that to assess what is going to be included in next year's web seminar series. And again, thanks, Gloria. Great presentation. Thank you very much.
Thank you, Liz. Thanks, everybody.
Ladies and gentlemen, that does conclude today's conference. Thank you all for your participation.